so much for being here, everyone. I feel like this has been in the making for quite some time. And of course, had the inevitable nightmares last night that everyone was just going to hit snooze on their alarm this morning and we were going to have an empty room. So it is so nice to see so many of you. So we'll just start off with a couple of intros. I'm Polly. I'm a senior partner at TPXimpact, and I oversee the work that we do with not-for-profit and the charity sector.
I'm Jess. I'm also a senior partner at TPXimpact, and I work on our health strategy and with our health clients. And I'm going to hand over to Adam.
Thank you. Hi, everyone. My name's Adam, and I'm a strategy and impact consultant here at TPX. And I do lots of quantitative research. So thank you.
Okay. I'm going to move on just to introduce our amazing panel. We are so grateful and very privileged to have all of you here with us today. Thank you so much. I'm going to leave you guys to introduce yourselves quickly.
So my name's Libby Rhodes. I use she, her pronouns, and I'm the head of digital transformation at YoungMinds.
Hi everyone, Sarah Fisher. I'm a Deputy Director in the Digital Prevention Services portfolio in NHS England, specifically on digital screening. And I think I'm also in charge of the mic, so watch out.
Hi everyone, I'm Nick Ridgman. I'm the Head of Support Services at Prostate Cancer UK.
Thank you all. So we are here this morning to talk about health prevention. And as I said, this is an event that we've been talking about doing for some time. We really wanted to bring together all of your expertise and experience and thoughts about health prevention, particularly around the NHS's kind of long-term plan around sickness to prevention. So very excited to start the conversation today. I'm going to hand over to Jess, who's going to kick us off.
Cool. So why health prevention? Why did me and Polly sit there and go, I think we should do an event about health prevention? Firstly, we know that it leads to better health outcomes. So it may sound obvious, but if we can identify sickness earlier on or even prevent it, it means it's a better outcome for people in the UK. Secondly, that means that's a reduced impact on our downstream services. So we know there's a challenge around waiting times. We know there's a challenge around A&E. So actually, if we can reduce the impact further down, that's a great benefit. And then lastly, it's a reduced cost to the public. So if we can prevent a lot of this sickness and illness that we have, it'll actually reduce the cost of our national insurance. Can you be my glamorous thank you, glamorous assistant? And then, obviously, it's also on the government's agenda too. If anyone has gone on and used the Change NHS campaign that's around, engaging the public in its 10-year plan, you may have seen it on BBC News. There's a clear focus on preventing sickness, not just treating it. And also in the autumn budget, there was a big aspect on addressing health inequalities with targeted investments in preventative care and community health initiatives. So it's clearly also on the government's radar. But what exactly is health prevention? It's a really super broad topic, and it got me and Polly thinking.
It took us a little while to find a definition that kind of felt like it made sense to us. And we really like this one, although I'm sure it will be expanded on a bit today. The prevention is about stopping people getting ill in the first place or helping people manage their health when they do get ill so that they can live happier and longer lives. And that's from Hugh Oldwick at the Health Foundation. But we know that this is an effort from across the system, that actually every single part of this system is an absolute key player. And actually, if we are going to move from sickness to prevention, it happens right in the middle here. So we know the importance of obviously the work that we're going to be hearing a little bit more about today from the NHS, vaccinations, screening, health checkups, rehab, chronic disease management, but also the work of our government. Things like our housing, our workplaces, the communities and the environments that we live in and those services that we can access to support. And also charities playing a fundamental role in providing information support to people from the moment that they are diagnosed with a long-term health condition through specialist advisors, things like self-support, peer support, and an extensive range of information support. So we know that actually prevention is about partnership across all of these systems. There are some amazing examples of where this is working really well, and a lot of learnings, I think, for us to kind of take forward.
So there is a nice, neat set of buckets that you can put prevention into. So you've got primary prevention, which is preventing the onset of disease or injury before it occurs. So things such as vaccinations and health education. You've then got secondary prevention, which is detecting illness early and intervening to prevent progression. And then lastly, you've got tertiary prevention, which Nick's going to talk about a little bit later, which is reducing the impact of an existing disease and managing its complications. And then when we think about different approaches to those interventions, you've got everything from policy change to services, you've got screening programs, rehabilitation, campaigns. And I'm just going to talk through a couple of examples to kind of bring it to life. So firstly, Catch to 5K. I've done Catch to 5K, got me into fitness. But this is a great example of a digital service that has really helped people kind of think about and manage their fitness and manage their health and getting people started. We've then got Copper Feel. So there's great campaigns that are out there. This is one that's really well known. You had kind of Cara Delevingne fronting it. And this is about regularly checking yourself to raise breast cancer awareness. You've got things such as policy. So the mental health bill came in 2024, and there was great collaboration from across YoungMinds, and lots of mental health charities to engage with the government to think about what that act needed to have and co-designing policies around it. You've got testing. So you've got Sexual Health London, which is really innovative in this space. It was one of the first kind of at-home testing kits that you got through your letterbox. And it's very much a self-service. And that's around kind of preventing sexually transmitted infections. And I'm going to hand over to Adam, who's going to chat through some cool stats, hopefully.
Yeah, hi everyone. My name's Adam, and I'm going to give, as Jess said, some cool stats and put some numbers and some context around the pressures on health and how prevention can help. So the context. We know that the UK population is getting older, it's getting bigger, and increasingly getting more poorly. Currently, there's 2.8 million people who are economically inactive due to health issues, and 3.7 million people living with a condition that limits their ability to work, either by reduced hours or by limiting the roles that they can do. There's growing incidence of many different diseases, such as mental health issues, with younger people experiencing a probable mental disorder more and more commonly. We also know the pressures are huge on the healthcare system, but also on social care and other support structures around that. And what we see is this kind of dual forces impacting, where we have a more poorly population that needs support, treatment, and help, and a reduced ability to pay for that by a reduced tax base. So there's real pressures, and something needs to change. So this is one of the main drivers behind wanting more preventative healthcare. I wanted to illustrate this by showing the scale of a problem of one disease, obesity and weight issues, and explaining how that is spread across society and how that's distributed. So one study estimated that as a total cost to the UK of £98 billion per year, and the vast majority of that falls on the individual and their families. So obesity has many impacts, such as increased risk of type 2 diabetes, increased risk factors for cancers, low quality of life, and early morbidity. And combined with the informal social care that is provided to them by their families, this equates to over £63 billion per year. So a huge impact. On top of that, you've got direct costs to the NHS, such as treatment and support, and an impact on productivity to GDP as well, adding up this huge impact on the country as a whole. Obviously, obesity has many different influences and factors and causes. So this isn't just an issue for the NHS. So how can prevention help? One study showed that by reducing the incidence rates of 6 major diseases by 20%, there'd be a huge impact on how the country can pay for things. Better health, increased tax, and increased labour force productivity, which leads to an overall impact per year of 20 billion by 2030, which then multiplies over the course of that individual's life. As well as this, you get reduced health inequalities, reduced pressure on services, and a better quality of life. So an overall great impact. And that all sounds really great. But obviously, it's not just a health issue. It's not just an NHS issue. It needs to be done holistically. And a system problem requires a system solution. And we're going to hear some really great speakers from healthcare and from charities soon. So I just wanted to finish on a case study I found within adult social care, where a Scottish council has done really great things of implementing community-led support and changing how they deliver social care by focusing on people where they are, where they need support, and doing things with versus doing things to, personalizing that support, and getting to people earlier where they can kind of do hyper-local service referral for people with lower needs rather than focus on people at the point of crisis, which is previously what they were doing. And they've had really, really great impacts. So they've reduced their adult social care waiting list down from 650 to 100. They've increased the quality of life for their residents, and they've delayed spend on residential care for councils for a number of individuals, which obviously has a great economic benefit for the council themselves. That's pretty much it from me, but I just wanted to do one last project shout out to a project TPXimpact is doing with the MHCLG, which is open referral in the bottom right-hand corner. This is an open data standard that helps councils, ICBs, and community organizations manage, publish, and distribute their data across different digital front doors to give residents a more seamless experience around how they can find community support. So if you're interested in that at all, please come say hello and I can direct you to find out more. But thanks very much.
Hi, thanks so much for having me. I feel really intimidated being on this panel because I have only been in healthcare for about 6 months. But before that, I worked across government in a range of different departments, HMRC, Department for Education, doing digital transformation. So I'm going to talk a bit about what my kind of prescription is for the NHS in terms of delivering excellent digital prevention services. And I think my hypothesis is that the prescription is actually getting back to the basics. It's quite simple. We can sometimes overcomplicate these things, but I think the NHS has a lot to learn from other government departments that have done this really well in the past and continue to do it really well. So I'm going to talk a bit about that. But I'm going to start with some facts and figures. I was going to do this as a quiz, but I think that might be a little bit unfair. And I would have to get Adrian and Emma not to answer, of course. But 10,000 is the number of lives that screening saves each year. So every year, just our existing breast, bowel, cervical, etc. screening programs save 10,000 lives. That's massive. I'm sure I don't need to say. But we do it through loads of paper. We send 20 million bits of paper every year inviting people for screening. Each of those bits of paper costs about 50p to post and print. So you can imagine there's a real financial and environmental impact from that, not to mention the impact for people receiving that bit of paper, having to ring up to change their appointment, etc. 70% is the average uptake of bowel cancer screening across the UK, but 10% is the uptake in the most deprived regions of the UK. So there's a huge discrepancy in uptake, and you can imagine that drives real health inequalities. We know that incidence of these types of cancer are higher in more deprived regions. So I wanted to start with some stats just so we have in our minds as I go through the scale of the opportunity. I know I'm preaching to the choir. We all know there's a huge opportunity here. So I'm now going to talk a bit about the how. First up, sounds a bit dry. Government is really nervous about intervening with commercial partners. We are really worried that if we intervene in a market, we're going to stifle innovation, we're going to distort things. And sometimes that means that we're really hands-off and we let 1,000 flowers bloom. Some of them bloom as we like, some of them integrate with the NHS app, some of them don't. And I think I'm arguing that in the NHS's case, we could do with being a lot bolder in terms of saying what we expect, in terms of saying what we want and trying to drive the market to deliver that for us. That's a different approach. It's a bold approach. It's a risky approach, but I think it will help us get what we want from some of those markets. Related to that, I think in the NHS we need a real recommitment to working in the open, and I think it goes along with our ask of the commercial sector. So we need public APIs, we need public design histories. We have one, you should look at it, it's really good, but not every team in the NHS has them. We need to be publishing what we're working on, and we need to say when we're going to do it and what we're going to do. That's a bit scary. It requires leaders who are happy to take a risk, because we might say we're going to do something in 6 months and it takes us 12. But in my opinion, that's better than not saying anything at all, which is what we tend to do at the moment. This one sounds pretty dry as well, doesn't it? But we're going to do exams. It's actually, I think, since I've joined the NHS, I've been really surprised by how teams have kind of ducked and weaved around things like service assessments. I know the NHS was exempt from a lot of what GDS applied on other government departments, and I think we are worse for that exemption. I think teams building excellent digital prevention services need to welcome the kind of scrutiny that something like a service assessment puts us through, and they also help us connect into a network across government of people who are trying to achieve the same things that we're trying to achieve. And they help us show off we're building great things, and sometimes we don't share them as much as we should. So, to sum up, my prescription for the NHS: bold leadership, people who are willing to take risks, say what we're doing, say it publicly, open teams that are working in the open, sharing public APIs, being really bold and hands-on with the commercial sector, that are held to high standards through things like service assessments, and are really part of that network across government of good digital delivery.
Great. So thanks, everyone, for having me here. So as I mentioned, my name's Libby. I'm the head of digital transformation at YoungMinds. And yeah, so I guess when we're talking about prevention in terms of mental health, it's slightly different to some of the other ways that we talk about prevention. But the way that we're approaching it is to think about mental well-being as a way of preventing mental health crises. So why a focus on young people? Obviously, that would be our focus, being young minds. But 1 in 5 young people have a probable mental health condition, and this can affect all areas of their lives. So obviously, this is something that we as young minds wanted to tackle. So I'm going to talk through some of the transferable elements that I think we learnt about as we were designing a preventative mental well-being service, which we designed with the amazing TPX and Nina, who's here today. So we did have some other design principles, but I've just pulled out 3 that I think are hopefully relevant to some of you here. So I think the first thing we wanted to talk about is a service that's personal. So for us, because of the disproportionately poor outcomes for young Black people in terms of mental health, we decided to focus on them as a group. And you can see from these 2 quotes here that we really heard the need for something that's really personal and tailored for them. It's not in any way about just fitting existing services around different groups' needs. We also heard some insights from them around creativity being a core asset of their community. They rely on themselves, they support each other, and productivity is really important in a really hectic lives. So we designed a service that encouraged young Black people to explore their mental health through creativity and sharing and supporting each other through community. In our beta feedback, we found that what was most successful, well, one of the most successful things about the service is that it fits in with their lives, that it really feels like something that is for and by them. It's something they want to do, they can feel the benefit, it's accessible and tailored to them. So I think for prevention overall, what I'm trying to say is that it needs to acknowledge personal context, be flexible, optional, and fit in with people's lives. A service that's interlinked, so this touches on some of the points that you've already made earlier on. Obviously, we know that all of the services around young people affect their mental health and therefore their health in general. It can help them, so as you can see from the first quote, where people actually did get support in school, sadly not the most common story, or from the second quote where you can see, oh no, sorry, that's a different quote. It can also harm, like the systems around young people can also harm them. So we know that young people in the lowest income bracket are 4.5 times more likely to experience severe mental health problems than people in the highest income bracket. And mental health can be affected by so many systems around them, including youth justice, education, environment, the economy. So that's why we really wanted to think about the systems around young people. So referring to this diagram, when we were looking at the support available, we found a kind of gap in the middle. So there's people's personal support networks, which can be helpful, but can also be a bit lacking and can struggle from stigma. Or there's formal support, which doesn't really kind of act in the prevention space and can really be a last resort for a lot of people. So particularly for young Black people, they're massively underrepresented in community mental health and CAMHS waiting lists, but hugely overrepresented in crisis and inpatient support services. So this was where we think there was an opportunity to design a prevention intervention. So we designed something that works with personal support networks, with formal support, but critically is something that they can look at themselves informally in that missing middle. And again, I think this was touched upon in your intros. So we think it's really important that it's rooted in community. Again, it has the power to be really beneficial. So young people tell us that the most positive impacts on their mental health are family, friends, and music. But it can also be really harmful, like you can see in the second quote here. So we really need to try to counter some of those challenges and pervasive thoughts and actions. And the only way to do that is to work with communities. It can't be about one organisation kind of dictating how people should behave, particularly when we know that there's a severe lack of trust of lots of big organisations, sadly, including charities and some other bodies. So we think prevention needs to be in collaboration with community. So we worked with groups of young Black people to design the service. And what we've heard and what we believe about rolling it out is that it's going to be critical for us to work with different communities to see how it can really come to life in the future. So yeah, those are our transferable things that we thought might be interesting to you. The end.
So, like I said earlier, I'm Nick Ridgman. I'm the head of support services at Prostate Cancer UK, and I'm just going to talk through what prevention means in the context of prostate cancer and some of the stuff that we are doing about it at the charity. So, just to give a bit of context to start off with, cancers obviously really vary in how preventable they are. It's a bit of an old stat, but the most recently available one from 2015 suggests that around about 38% of cancer cases are preventable. But for prostate cancer, there is no strong evidence of any modifiable risk factors for getting prostate cancer at all. So because of that, naturally, none of our activity, either in the kind of support or influencing space, which is what I'm focusing on today, focuses on primary prevention. It's completely out of the picture, effectively. A couple of bits of context here as well. So first of all, we've spoken a little bit about screening already. There is no screening program for prostate cancer in the UK. In its early stages, prostate cancer has no symptoms. And as of yesterday, officially, it is now the most diagnosed cancer in the UK. So because of all of that and because of there being no primary prevention possibilities, we instead focus strongly here on risk awareness. So looking at age, family history, ethnicity. So just a bit of a run through there of some activity we've done over the last few years. Going back to 2022, Find the 14,000 Men looked at post-COVID recovery and getting men back into the urology pathway where they'd been misdiagnoses. We've done work around regional inequalities in early diagnosis. Obviously, a strong and consistent support on the Black community because they have double the risk of prostate cancer from other men, and working alongside celebrities in their moments of kind of sharing their diagnosis. All of which underlines this messaging around risk awareness and all of which points men back to our 30-second risk checker, which can help them to make an informed decision as to whether they want to ask their GP about a PSA test. And then alongside all of that, more in the influencing space, we are pushing urgently for guidelines change within primary care so that GPs can proactively offer the PSA test. And over the much longer term, we have submissions in with the NSC, which we're hoping to hear back from later this year, hopefully over the longer term working towards a screening program for prostate cancer. But I'm probably going to spend most of the time just talking here about tertiary prevention. So it got touched on earlier, and tertiary prevention is usually discussed in relation to long-term conditions. Now, in fact, the survival rates of prostate cancer are so high, 10-year survival in England is 80%. In many ways, it can be regarded, and we do regard it in many ways, as a long-term condition. So just looking there at some specific kind of scenarios around tertiary prevention and how we support. So active treatment for prostate cancer, whether that be surgery, radiotherapy, hormone therapy, comes along with pretty disastrous side effect profile. Now, if you get diagnosed with low-grade and low-risk prostate cancer, you're likely to be put on something called active surveillance, which means not having active treatment, monitoring the cancer through PSA tests and MRIs, and waiting until it progresses before you have active treatment. Now, when a man is put on active surveillance, it can be quite kind of an anxious time, knowing that you've got prostate cancer but not doing anything about it. And actually, a lot of men drop off that pathway within the first 6 months because of that anxiety that they can't cope with. So we know that staying mentally well and staying grounded during those 6 months can actually help with adherence. It can keep men on the pathway. And as part of our one-to-one peer support service at Prostate Cancer UK, we have a group of peer support volunteers themselves on active surveillance who are able to kind of help men through that, do a bit of role modeling to say, look, I've come out the other side. I'm here 3-4 years into my active surveillance journey and I'm perfectly well. And we've seen that helps men to stick with active surveillance, which obviously delays treatment, delays that side effect profile, delays the cost to the NHS. And also staying physically well on active surveillance can actually slow the progression of the cancer and, again, delay the point at which you need active treatment. So therefore, it's not just about giving our really high quality clinical health information. It's actually about having well-being content around diet, exercise, and so on to help men stay well. Thinking about side effects, another big consideration within prostate cancer is sexual well-being. So sexual dysfunction is a huge side effect of all of the prostate cancer treatments. And we know that having effective sexual prehabilitation and rehabilitation can significantly improve quality of life and well-being. We're doing some work with Movember at the moment, looking at designing a sexual prehabilitation service, which we're going to pilot, hopefully in a London trust within the next year, and then roll out to some targeted areas, looking at kind of areas of deprivation, those areas that we looked at earlier in terms of inequalities around late diagnosis and so on. And just finally, hormone therapy, which is a treatment that men with advanced prostate cancer can live on for a long time, sometimes decades. We know that for men on hormone therapy, effective self-management can really enhance quality of life, and that tailored diet and exercise can safeguard against the risks to bone health, which come from hormone therapy, and also metabolic risk. And within our service environment, we have a group of our specialist nurses who run hormone therapy classes. So those are kind of like small groups. They blend the kind of more formal clinical education with small group peer support and also kind of goal-setting exercises so that men can identify those well-being goals and stay well on hormone therapy. And that's it. Thank you.
So thank you so much to our brilliant speakers. We are going to do a little bit of Q&A now, but don't stand on the microphone lead. And I'm actually going to kick off with a question for you all. So my question is, obviously you've hopefully seen the big 10-year plan, and you'll have seen the campaign that's going around. You may or may not have actually actively gone on and been part of the campaign and put a comment on the channel and thought about what you would like it to be. But either personally or professionally, if you were to write a comment on the campaign, what would that be?
I'll take the hospital pass. I guess this is going to sound a bit woolly, but I think when I'm thinking about prevention, I always have that focus on health inequalities. So it's important to remember that some of our preventative work actually makes the gap in healthy life expectancy worse. So things like the Change for Life campaign, great campaign, actually worsened health inequalities because people who are already worried about what their children are eating worried even more. And so the gap kind of gets bigger. So I think it's a bit broad, but my real plea, I guess, to policymakers is to think about ways of closing that gap and not just thinking about how do we make people who are already really worried about their health even more worried and even more healthy.
Thank you. So for Prostate Cancer UK, the biggest part of our submission was around early diagnosis, but we did add a bit to it, particularly off the back of some of the work that we've done with TPXimpact and a group of charities looking to initiate direct referral pathways from the NHS into charity supportive services. And so I suppose looking slightly more broadly than that, a big ask that I would be really keen to see would be more openness to working with health charities to leverage the capability that they have with supportive services. I think along with that comes a responsibility for charities to kind of step up, professionalize their services, evidence their impact, which is something that we've been doing as part of that group. So I think it cuts both ways. But I still think there's a massive missed opportunity in terms of with some of the stuff we've looked at there in terms of quality of life, well-being, all of that stuff can be evidenced and can be costed. And I think health charities are a phenomenal resource and can play a big part in supporting the NHS with that.
Obviously, I think I'd want to have a bit more of a mental health angle and for us to be thinking about mental health alongside our physical health in all that we do. The waiting lists, particularly for young people, are abysmal, and the harm that comes to young people while they're waiting is horrific. But obviously, if we're talking about prevention, we need to be thinking about mental health as well, because the knock-on impacts on your physical health are huge, and the Mental Health Act just completely needs revisiting, I think. to put it politely.
We don't need you to be polite, Libby. Thank you so much. And yeah, thank you again for those presentations. And amazing to kind of see prevention through the kind of different lenses of your organisations and the work that you do. So thank you for taking all the time to put those slides together and present today. So now I am looking to you all and hoping that we have some lovely questions for our panel. Does anyone want to kick off? Lovely, thank you.
Can you hear me?
Yeah.
Just speak up.
Just shout that.
Yeah, so something I learned which is quite interesting today is that 1 in 4 black men suffer from, or more likely to get prostate cancer. I think one of my friends' dad died from it, but they caught it late, as you mentioned. But like myself, I'm not really aware of it. I don't really know much about it. And I'm wondering why I'm not aware of that information. I feel like I should,
So, how do I give the short version of the screening dilemma with prostate cancer? So, there's the reason you probably haven't heard of it is because there is no screening program for prostate cancer. So, with bowel cancer, for example, a letter will drop through your door once you reach the age of higher risk. With prostate cancer, the PSA test is the first step on the diagnostic pathway for prostate cancer, but it's not the perfect test for prostate cancer. It can come along with false negatives, false positives, and if you catch prostate cancer but it's low grade and low risk, it might never need treating, but you might choose to get it treated anyway. So there's all these complexities as to why the balances of risks and harms around the PSA test mean that there's no screening program. Now, we are doing various things about that. So over the much longer term, we've got a clinical trial that we've just kicked off called Transform, which is going to be a long-running thing, but that will get us to screening probably within the next 8 to 10 years. It might come sooner because actually, as a charity, we say the balance of risks and harms has changed. The last big screening trials done in the UK were some years ago, and a lot of stuff has changed in the pathway in terms of not having biopsies and so on. That our position is that actually the evidence is there now, at least for targeted screening, i.e. for men with a family history and black men. But of course, where there is no screening program at the moment, that means that wider awareness is quite hard to cut through. And I think the other thing as well with prostate cancer is that when you look at a lot of the generic NHS campaigns around catching cancer early, it's around symptom awareness. It's around kind of trusting your instincts, listening to your body. If anything doesn't look or feel right, you go and get it checked out. It just doesn't work for prostate cancer. In its earliest stages, it very rarely has symptoms. By the time it does have symptoms, sadly, it's usually metastatic, stage 4 prostate cancer. Now, men can still live for a long time on those long-term treatments, but it is incurable at that stage. So yeah, it's tricky. It doesn't behave like a lot of other cancers, and we don't have that screening program. So that cascade of knowledge and awareness just doesn't happen. And that's why we put so many eggs into the kind of risk awareness basket, really, in terms of our activity.
I was just going to quickly add, I guess, from our point of view in digital prevention services, I think our vision of the future is that people will have much better sense of their individual risk level, so that they'll be less focused on, like you say, those kind of big population campaigns, and more through digital tools, ability for people to see and understand their own individual risk level, because it varies so much for some of these conditions.
Just on the digital front. So, I got all the social media channels, TikTok, everything. And the algorithm will give me loads of different types of adverts. But I've never seen anything about that pop up. Do you know why that is?
Good question. I don't. I know the NHS does do a lot. I think they did a lot on TikTok around like cervical screening in particular. So like, here's what's going to happen at your cervical screening. Here's why it's not a thing to worry about. But I don't know if we do kind of prostate cancer awareness on those channels, but I can look into it.
Thank you so much, both. Question at the back.
Question for Sarah. I was just curious, you made a really good statement about being bold with your decisions with the commercial sector specifically. And I was wondering, hoping maybe you could give us, with nobody repeating it outside of this room necessarily, what might be an example where you think a bold decision to the commercial sector from the NHS could make a difference? Give us an example of that.
It's a good question. I guess my sense, and as I say, 6 months in, but we have a lot of trusts buying things directly from private suppliers, and I think we could be much stricter in the requirements we set in terms of like integrates with the NHS app, for example, where there's a bit of a kind of patchwork in terms of what suppliers offer at the moment.
Thank you. Kate at the back. Oh, Kate, did you have a question?
Oh, I did, but I hadn't got my hand up there, Polly. So
I was reading your facial expression. Sorry, one at the back.
Hi. A question to anyone in the panel. So I know that there's screening for things like cervical cancer and, you know, I guess when you get to 50, I think it's something like that, so they kind of get you in into a few, like, I don't know, college or whatever. And I understand that screening costs money, but it seems like it's all behind a kind of age wall or a risk wall. What's the kind of, not what's the data, but I don't understand why there's more screening. I know it costs money, but does the cost of people getting ill not sort of way more than, because like as for gynecology, for example, like my doctor said, well, women, you can't just come in and have a check. You've got to wait till something goes wrong. And that just seems crazy. But I guess it's cost, but I just wonder what the cost is versus the long-term effects of getting on well. I don't know if anyone knows anything about that.
That's a good question. I guess I'll start and then maybe you can talk about it because it's quite relevant for prostate screening, isn't it? I guess there is always a cost angle, but there's also always a risk with screening programs that you overdiagnose. So you identify something, someone has to go through what in some cases will be quite painful chemotherapy, etc. And actually what you've identified would never have progressed into full-blown cancer. So there is overdiagnosis in screening. So that the balance that our sort of clinical colleagues are always trying to arrive at is the risk versus the harm, because screening is generally a good thing and it identifies lots of cancers early, but it comes with a risk of you over-treating people for cancers who didn't need treatment. So there's a sort of societal cost to those people of going through that process. So I guess relevant to prostate cancer, because that's kind of what the decision that you're working through at the moment is.
Yeah, I mean, that's pretty much it. I spoke earlier about active surveillance and, you know, in a situation where, so like if you run the argument through and we bring in screening and the age is too young, say 40, you're going to pick up a lot of those kind of cancers. Slow growing, low risk. And what you can't guarantee, I mean, ideally what would happen for those people is they would go onto the active surveillance pathway, which is lower cost, you know, but there is still cost. And it's actually not just, there's got to think about things like MRI scanner capacity as well and things like that. That's going to be a big question if and when a screening program comes in. So ideally men go onto the active surveillance pathway, but actually there's no guarantee that they will. And a lot of men, like I said earlier, they can't cope with the idea of having cancer in their body that is untreated. And then they get radical treatment for a cancer that never would have harmed them. And I mean, not to labour the point, but the side effect profile for that it can be disastrous. Now you're talking about urinary incontinence, very acute after the surgery, and then potentially lifelong. Sexual dysfunction, some men never regain erectile dysfunction after that treatment. Now think about what that means to a 40-year-old man, you know. So it's there's the cost element to it, and then there's the quality of life element to it, and both those things are held in a very complex balance that I'm glad I don't make the decisions around.
Yeah. I suppose the one other thing, sorry, I'm not going to go on, but when you were to say to a guy, right, you've got this, but we recommend you don't do anything about it, like the mental load must be so heavy, because I suppose there's not, I mean, I'm not a dude, but I don't know if guys understand generally that if you get it, it's probably going to be okay, or it's a really good chance it's not going to really have a lot of effects. So as soon as you hear that diagnosis, it must just be like, oh my goodness, what am I going to do?
Yeah, and you can tell, you know, you can understand it I've been working at Prostate Cancer UK for 3 years now, and I know the facts about it. I know if someone were to get a prostate cancer diagnosis intellectually, like what does that mean? that can't compare with the emotional shock of getting that cancer diagnosis and knowing that you've got that in your body. When the catastrophizing and the worst case scenario, so many men, even on an intellectual level, will know I probably don't need to treat this, but I can't cope with this idea of leaving it. So
the answer is to... What's the answer? How do you get guys to stop panicking as much? Is it education? I mean, I was just I'm from breast cancer now. I was a nurse in the NHS for 25 years for this job, and I think, some of it is the complexity of cancer. So, breast cancer, they're not the same. So then if you're having this kind of cultural conversation about early detection, it can, really improve outcomes. And then in another sense, say early detection can sometimes mean you don't need any treatment. It's trying to get that balance, and it's the complexity of cancer for that. And, the breast screening program is a population-based screening program. So you need a certain amount of people to attend that screening for that to be of benefit. And so, going forward is, in breast cancer, is it can we better identify those people that are at increased risk, so that you can stratify screening, so that you're screening the more people at risk rather than this kind of population-based. Thanks.
Oh, yeah. Last three. We've got time for three. Last three. At the back. I think we've got at the back, and then to you, Kate.
Was it correct? So I'm going to butcher the facts of this now. I think you said 70% of the letters that get sent out result in people actually following through with screening. I think it was like 10% or under, where there are pockets of deprivation actually that drops down. What are the factors that, because 70% was quite high, but just a letter to about 50p to be actually 70% of people that are going to screen. But that drop is so significant. What factors actually result in people not only 1 in 10 people only going to screen?
Yeah, it's a really complicated picture. Some of it is actually sending letters is not always a good way to reach people, particularly in deprived areas where there's really high rental accommodation. People are moving a lot. There's no guarantee that letter is going to reach that person. So some of it might be that they never even see the letter. Some of it is when you're balancing a really busy, complicated life, that might be going and having your bowel screening might be quite low down your priority list. And some of it is people are scared. And we know particularly with bowel screening that even people who get a result that there's something, they need to come in for a colonoscopy, there's something that needs to be looked at. A lot of people, particularly from more deprived areas, don't respond to it because there's a fear around, what does this mean for my life if I have to go through treatment for bowel cancer? I just can't kind of face it. So there's a whole myriad of factors, and they're complicated to address because some of them are practical, like are we reaching people? And some of them are emotional and fear-based, in people being kind of nervous about what a diagnosis of bowel cancer might mean for their life.
Thank you. Kate?
Thank you, Polly. I've got a question for Libby, and it's about the support tool that you developed for young Black people, which I think looks amazing. And my question was, did you have, about two parts to it, did you face challenges when you kind of get that building trust and support and buy-in from young Black people when you're developing the tool? And then sort of a related question is, how do you make sure that you're able to kind of reach them and how do you get the tool out there and make sure that young Black people are aware of it and are using it?
So it's at very early stages at the moment, and actually one of the things that we did discover from our research was that a lot of the young Black people that we spoke to didn't know about YoungMinds, wouldn't turn to a national charity. There's a lot of assumption that, well, a fair assumption that a lot of national charities are very white-focused. A lot of services have been developed in a very westernised, white-focused way historically. So that is something that we'll be working to overcome throughout it all. We work very closely with quite a small group of young people, so we were able to build the trust with them, and they were co-designing the service to really, one of the things that was really important from the research and through co-design and through our beta testing was that it feels like it's for and by young Black people. And so we've been having discussions about whether it even should be a Young Minds service or whether it's something that we could do in partnership with other people. There'll obviously be a really massive need for community engagement. We've got incredible kind of on-the-ground community engagement work happening at Young Minds, and we want to work really closely with them. But yeah, I'd say it's something that we're so aware of. Like, it's something that you need to kind of consider when you're trying to work with groups that you don't typically reach for very understandable reasons. So something we're still working through, but trying to do that really intentionally by working with those people, the people that it's for, to be able to give it kind of so it's theirs, and they can almost talk directly to their peers, hopefully. But yeah, very early stages.
Thank you. Ime, next question. Yeah.
So I think what's coming to mind for me is I love the national charities, NHS England, and you've spoken about community, you've spoken about personalisation. I think what's coming to mind is, what have you learned about the role of local authorities and GPs, and the support that they will need, and how you're engaging with local authorities and GPs? And maybe Adam, you might be able to talk a bit about that referral route and what that might look like. That's the only thing.
Yeah, could do. Again, that's something that Young Minds wants to do more of, is working with GPs. I think part of the problem is, for young people's mental health, going to your GP is a big step. Even they're amongst the group of people that often aren't trusted, who deliver services that aren't right for you, might not believe you. Sadly, it's a tricky thing to overcome. So Young Minds have tried through various campaigns to encourage people to go to speak to their GP. But I think something around like being in the community and that peer support and knowing when you need to seek that kind of formal support is quite important. And that's why we were focusing in the middle between like the personal support and the formal support, to say you can look after yourself. Like, people are looking after themselves amazingly and each other, because a lot of services are failing them. But we're hoping also by being in that space, we'll be able to encourage people to, when they need to go up to those other places before it reaches crisis point, because when there is such little trust, obviously it takes you getting to that point sometimes before you actually seek that clinical or professional support. It's not an answer, but it's basically an acknowledgement of the challenge that Young Minds is trying to look at. But yeah, open for more discussion, I think.
Yeah, it's an issue that a lot of the councils we've worked with really struggle with. It's often the really formal support networks and kind of pathways are for people who are within crisis. But over, I think, 55% of people who ask for support don't receive it or get referred to a universal community service. And those ones are the really ones that kind of break down a little bit, because those are the ones that are lower needs and eventually end up, if you don't get that help and support, they end up in kind of, can end up in crisis. And what we heard was a lot of either community workers or social care workers kind of really had to rely on a little black book. And it was totally dependent on who you spoke to within that council, what kind of support you got, whether they knew people in the community they could refer to, like these hyper-local services, which are kind of very fragmented by nature. It was really difficult for them to find those kind of referrals. So I think what we've been trying to focus on is trying to help provide that more seamless place-based approach where, if you're a community worker or a social worker, that actually you have a repository of information of these different services that is up to date and accurate. So when you try and refer someone to them, it works, because often, you've got one opportunity to do this, you're one point of contact. If you don't take that opportunity, then that person gets, disinterested. They call up the number and that, it doesn't work, or the service shut down 3 years ago, or, even things like summer activities for children with special educational needs. The parents will try and use the council website to find these activities, and it's from 6 years ago. So they don't use that resource, and then the council doesn't think it's worth investing in keeping them up to date. So it's a really negative cycle. So it is a real challenge, and it's something we've seen play out a lot.
Thank you so much. Oh, do you want to add something, Nick? Go for it.
That's all right. Yeah,
yes,
just quickly.
Go for it.
So, I mean, for us, in the way that we engage with GPs, it's typically around the PSA test and making sure that they're up to date with the guidelines. So our education team do a lot of work with GPs at large to make sure that they are following guidelines. in terms of kind of referral into our supportive services and making sure that people are aware of what we can offer in terms of our specialist nurses, our health information and so on, we're mainly relying on secondary care because that's where men are held and treated for prostate cancer. So you're looking across urology and oncology. So we've got a kind of stakeholder group we've got a clinical advisory group where we've got quite a lot of kind of clinicians from across the country. We're never going to reach anyone. Effectively, we're relying on a good brand, people being aware of who we are, having kind of champions out there in the community who kind of go back into their trusts and spread the word about kind of what we can do. But again, it's patchy. We know that there are some bits of the country where we have really good cut through with our supportive services and others where it's less so. And it's no surprise that, going back to the theme of regional health inequalities, it is those affluent areas with good teaching hospitals, et cetera, that they know about us and they refer to us. So yeah, we're very cognizant of that. And where we do look to do kind of bits of targeted promotion for our services, kind of straight to consumer, we prioritise deprived areas where we know we don't have that cut through.
Thank you so much. Nick, Sarah, Libby and Adam, thank you so much for joining us this morning and for being our panel. And thank you so much to you all for joining us as well. We have time now, for anyone that can stick around. Don't know what the croissant situation is like, but do go in for seconds if you'd like. And hopefully our panel can stick around for a little bit longer as well if anyone wants to follow up. Big thanks as well, actually, because although we fronted this, there are TPX colleagues all around who made this happen this morning. So thank you so much to them. Thank you. Enjoy, and thanks so much for joining us.